have, we take the decision still at 28 weeks. Okay. So the safer terminology to be used is age of viability, and it was needed a death of the baby, not expulsion of the products. It can be anything. So the word you are supposed to use in exam is termination of pregnancy. You understand the difference? Termination of pregnancy, not expulsion of products, and not death of the baby or fetal demise. It can be both the things. Okay. Now, these abortions usually present with bleeding for the child and pain after. In a mixed combination, in some abortion pain will be more, bleeding will be less, but it is a relative thing. That's how we diagnose various kind of abortions. So how the spectrum goes? Threatened abortion means the uterus is threatening the doctor and threatening the patient, showing red signals and little pain, and showing if you don't take care of me now, I am going to abort this pregnancy. So this is a warning, threatening for the doctor as well as patient that take care of me now, otherwise I am going to terminate this pregnancy. So what should we do? This patient will have little bleeding and little pain. Sometimes only bleeding, no pain. Okay? So both the things little. And if I ask you what is the treatment for this? Treatment for this pregnancy is you give progesterone, you give mental physical rest, and you try to continue the pregnancy. Okay? You say, sorry, I'll do my level best and let's continue the pregnancy. Second kind of abortion is inevitable abortion. It might be the second, and you have not listened to that warning. That means the body has already started expelling the baby. The products might be lying in the cervical canal, they are already detached. Now, even if you try, you cannot save this pregnancy. So what should you do? You should evacuate the products, because if you do not evacuate, patient will keep on having bleeding, she will have infection, can lead to sepsis, and patient will keep on having pain. You know that this pregnancy has gone beyond the point, now you cannot do anything, so better to help the patient by removing the products of conception. Is it clear? Okay? And all these things you have to do. You have to take history for how many hours, how the bleeding is happening, bleeding and pain, how much is the severity, do the examination. So many times, threatened abortion, when you do spectrum examination, cervix will be totally closed. Okay? And when you do SE inevitable, there can be sometimes cervical os will be open, or sometimes thus you might be seeing coming in the vaginal canal. Third kind of abortion is incomplete abortion. Incomplete abortion means patient comes with lot of pain and lot of bleeding, and when you do examination, then you see how the products are already out. Is it clear? So what you will do? Incomplete abortion, what you will do? Do you continue pregnancy? No. Do you let the patient go back anyway? It is incomplete, it will be complete? No. Because patient has come to you to complain of bleeding and pain, you again evacuate the uterus. Okay? Fourth kind of, the last in the spectrum is complete abortion. Now what happens in complete abortion? Patient will say that 5 o'clock when I had, throughout the night I was bleeding, I was having severe pain, then I passed some clot-like thing or some fleshy mass kind of thing, depending on how much clever your patient is. And but now since morning, 7 o'clock I am renewed. Now no more pain, no more bleeding. That means pregnancy is very good going inside? No. That means patient has complete abortion. Now when you do spectrum examination for this lady, what will be the finding? Os would have been closed. Patient is, so everything is complete. What do you have to do for this patient? Do you evacuate the uterus? No. Everything has been taken care of it, and you just have to counsel the patient, tell that this was the thing that has happened, and you do not need to interfere. You understood this? So if any question is asked in incomplete abortion, you have to write about what incomplete abortion is. You have to write about what will be the complaint of the patient. You have to write about what will be the speculum examination finding and how you are going to treat it. So I hope you will be able to write this. Now coming to the other side. Then there will be some other types of abortion outside this spectrum. Can you name a few? Induced, very smart. One can be induced abortion, but before that I want you to, there is something called missed abortion. What is missed abortion? Missed abortion also body, that's why I said that don't say expulsion of products, because every abortion you do ultrasound, then you come to know baby is dead. There was cardiac activity before, there is no cardiac activity now. Are you feeling sleepy? No, she's feeling so sleepy. Give her a chocolate. Chocolates are better today? No chocolates. Okay? So, you understood what is missed abortion means? Baby is dead inside, but usually body will take action and the fetus is not good, but this time somehow body has not pursued it and it is not going to abort. That is called missed abortion. Patient will not come with bleeding. Patient will not present to you with what we call excessive pain. Some little brownish discharge can be there. When you do ultrasound, everybody is sleeping. What do I do? The second girl, you don't say, my fellows doctor, my sleep is sleeping. Don't sleep, I say my goodness. Okay? So, you understood what is missed abortion? Okay, let's move on to the next thing. Next is induced abortion. I'm not going to talk. What is the name of induced abortion? MTP. You know everything about it. There is a big thing you should read, and there are some amendments that you should know because you might get a question on that. The third kind of abortion that also you can be asked. Nobody is going to ask you detail about it, but recurrent abortion. Again and again abortions are happening. And when we say don't get confused, when we are saying recurrent, I'm not saying in one pregnancy only 3 times patient came with bleeding and pain. It's not recurrent. Recurrent means complete abortion has happened, spontaneous kind of, and it is not 3 MTPs also. Okay? So 3 times or more if it has happened, but if patient says, doctor, I got my MTP before marriage 3 times and once after marriage, don't label this patient as recurrent abortion. Okay? That is not recurrent. Recurrent abortion will happen and it is a spontaneous abortion. Is it clear? Should we move on to the next topic? Oh, before that question. Chocolates really don't have what? Who will read the question? Please read the question or sleeping person. Can you read it and know that?
My name is Ashwara. Which of the following abortions will not present as bleeding in pregnancy? Option A, threatened abortion. B, complete abortion. C, missed abortion. D, induced abortion.
Yeah, let's see if you will answer this question. Next. She knows she is smiling everywhere, but what are the years?
Missed abortion.
Huh?
Missed abortion.
Missed abortion. Anybody has any confusion in that? Missed abortion is the answer. Okay, understand the question. What is read the question? Yeah, you have the mic. Please read the question.
In which of the following abortions the aim of treatment is pregnancy continuation? Option A, threatened abortion. B, inevitable abortion. C, incomplete abortion. D, missed abortion.
Tell me loudly so I can hear it. Threatened abortion out of this is only one abortion that we want to mention. Is it clear? Okay. So don't get confused if asked your exam. Now coming to ectopic pregnancy, quickly finish all topics. So what is ectopic pregnancy? All of you know ectopic pregnancy is a pregnancy which is outside the uterus. Most commonly this pregnancy occurs and there up to 12 to 14, some cases up to 16 weeks also. Okay? Now, unruptured ectopic. How do you discuss? Ma'am asked a question that unruptured ectopic. Somebody said ruptured ectopic will present with bleeding. You said ruptured ectopic will present with bleeding. Any ectopic, unruptured or ruptured, can present with bleeding. Ectopic pregnancy with ruptured ectopic will present with hemorrhage bleeding inside the ectopic. Okay? Because of decidual, low levels of progesterone just dropping down, decidua coming out that time, patient can present with bleeding, but definitely this bleeding is not like incomplete abortion or with history which patient is in. There will be little bit bleeding, but that thing, what you are thinking that if ruptures means suddenly bleeding will come out, that bleeding is not going to come out through vagina. It is going to fill up the abdominal cavity. Okay? So how do we unruptured ectopic is very good. If we are, when we were in PG, our ma'am used to tell that, Kiran Pandey used to tell, and that all Pandeys tell nice things. Okay, so ma'am's name is Kiran Pandey, so she used to say that if you don't want to miss ectopic pregnancy, maybe every pregnancy can be an ectopic pregnancy. That high level of suspicion you should have. Okay, so I'm not going into details how you suspect, but there are some. If patient presents in early pregnancy with pain, spotting, and it is all other things, you don't think it is a kind of abortion, you should amenorrhea, short duration of amenorrhea, little bleeding per vagina and pain abdomen. This tried whenever you should keep a possibility of ectopic pregnancy in your mind. Is it okay? Why it is important to predict ectopic unruptured ectopic early? Because if you can predict today, you can treat the patient without she using her tubes. If it ruptures one, what is the treatment? Self-injectory. Only one word you have to remember. The entire tube you have to remove. You cannot one piece you cannot remove because then you are making the tube more prone for further ectopics. So complete self-injectory is the treatment, and if you detect it, but what will happen? But tube if you remove, then definitely tube is a conduit, important conduit for pregnancy. So little effect will be there in pregnancy. So if we detect it at unruptured stage, what can we do? We can do what? Medical management. Tell me one word, what drug is used? Methotrexate. Difficult questions, all of you know. So, methotrexate injection, even single injection, that will take care of ectopic pregnancy, so you can do it. But unruptured ectopic, if it is ruptured ectopic, already patient is in shock, you have to rush her to OP. Because the bleeding from that patient is bleeding in ruptured ectopic. Uterine vessel, it is not in the uterus, it is a tube, from that the blood supply is coming. Ovarian vessel, ovarian artery is a very pressure, aorta, so patient is actually bleeding. So you have given a question that, which if you have two patients, one ruptured uterus, one ruptured ectopic, which one you will shift to OT first? Ruptured ectopic, though it was a small thing, but the bleeding is happening directly from the aorta, so because it's not that we keep the other patient out to it. Just a hypothetical question if I ask you, that is the answer. Okay? Understood? So you have to save the patient, but equally important, you don't wait for to give her blood and do other things. You directly shift to OT while operating to give her blood. Is it okay? You can write an answer on this. Question 3. Who will read? Aramamika will read that question.
Following strategies are used to treat ectopic pregnancy except A. Conservative management, B. Methotrexate, C. Salpingectomy, D. Hysterectomy.
Super. I thought I gave you a chance to choose the candidate answer. So sometimes at PTSD level of any look will get doubtful, less than 1000 usually. You can just wait and watch also and give conservative management, but hysterectomy you never do. Okay? Is it clear? Now, the third kind of thing which we are going to discuss, which again can present in early pregnancy one answer everybody. Like 10 questions, one answer. And I think more than 50% of students have done this directly by letters and we hope for it to be for evaluation. What are those systems and limiters? Themoid cyst. And what is the treatment of themoid cyst? Molar evacuation you do, you just follow observation after. What is the treatment? She has not heard the question also.
These are functions, ma'am.
So you don't have to do anything.
Reassurance.
Reassurance. And you have to treat the molar cyst. As this BTSCG level comes down, slowly they will come down. Okay? So that reminds me one more question I'll tell you. How completely undergraduate is answered. There was one question given this patient came and ultrasound, there was no absent heart. Okay?
Following are the causes of antepartum hemorrhage except placenta previa abruption placentae, molar pregnancy and several groups. Molar pregnancy.
Why did you say so?
It is first trimester will be happening molar pregnancy.
Please tell me correctly. Molar pregnancy is diagnosed with not antepartum hemorrhage. Understood? You want to ask something? Somebody wants to ask something? Is it clear to all of you what he said? All of you agree with him? Okay. Thank you. Okay. So, antepartum hemorrhage can be of two kinds. What are the kinds of antepartum hemorrhage? Abruption placentae and placenta previa. Okay. So, first maintained. Usually, baby is not affected, that's why they continue the pregnancy. Vaginal examination? Very good. So never do vaginal. When I was PG, I thought I got scoring. I remember the ma'am was there. I did the evaluation of placenta and sent her to past unit. She said that the patient started bleeding so much and we had OT in the first floor. We shifted the patient survived, but my 24 hours were late. I did a mistake, but it happens. Okay. Spectral examination you can do. If you have the diagnosis by ultrasound, then there is no need to do. So, abruption placental will continue. Abruption placental bleeding will be painful because the blood is getting collected inside in a small space between the placenta and the myometrium, and then it trickles inside the myometrium and causes pain because of activation of muscle fibers there. Is it possible? So it is painful. Question mark is there. Is it painful? Painless bleeding? No. It is painful bleeding. Is it causeless bleeding? No. Most of the times there will be a cause associated. Is it recurrent bleeding? We don't want to wait to see. We have to terminate because here the blood supply to the baby is getting cut off and we need to deliver the patient. Okay? Then second thing is pallor. What will be the pallor? It can be proportionate if it is revealed hemorrhage, but if it is concealed inside, you might have little bleeding but lot of pallor and tachycardia and hypertension. You have to see that. Fundal height can be normal and can be more if it is a case of concealed hemorrhage. So then the question is asked, causes of uterus more than the period of amenorrhea, size of fundal height more than period of amenorrhea. Normal students will tell all those things. Good students will tell this also can be concealed hemorrhage. And transverse line, the height will be less. So if you are trying for better marks talking the examination, you should remember those. So less height means transverse line, more height means one more cause. And don't tell it as the first cause, but it can be last on the list. So FHS can be bad, can be bradycardia or problem with fetal heart, it can be absent fetal heart also. Okay? And even if the baby's heart is absent, what is the treatment? Vaginal delivery, immediately, because the blood is going into the myometrium and patient already has some cause, so there are complications for mother also, like renal failure, DIC, all these complications shock patient can have. Okay? So one thing I want you to remember, all of you see Hindi movies? All of you have seen some Hindi movies maybe a decade ago when I was studying, there used to be, now I don't know whether they make it or not. So when movie scene used to be there, very common. When patient, doctor will come, gynecologist will come outside the OT and she will say to husband very sadly that he can save only one, mother or baby, whatever to save. Have you seen those kind of movies? We never do that. We never ask patient's husband and mother in law okay, this question is never asked. So much purpose Bollywood has spread about this, I can't tell you. Okay, we never. If we have to say one person, who is here? Mother always. Okay? We try to say both, but this is totally a lie and we go outside and ask, whom should I say? Okay? Question 5, great question. Choose Monica.
Please start.
Quickly. He has taken one case discussion yesterday, so he has to answer.
25-year-old private at 37 weeks, 2 days of gestation, presents profuse vaginal bleeding since 6 a.m. Not a good case. She is pale, pulse rate is 110 per minute, BP 100 bar 16 mm of mercury. Abdominal examination reveals longitudinal lie, cephalic presentation, mobile head, fetal hearts on 140. What is the best plan of action for this lady? Blood transfusion. Blood transfusion, emergency cesarean, package transfusion, wait and watch. eminently cesarean.
So what is the diagnosis to answer this question here? It is abruption.
Abruption.
Okay, abruption without vein. You can do, I told you, ectopic rupture, ectopic abruption. These are the conditions and these go side. Plan of action. I did not say what is the best plan of action. You have to think in abruption that you are shifting the patient. You don't wait for blood in the labor room or emergency. Shift the patient. You start cesarean whenever the blood comes to the transfuse. Understood? So that sometimes the questions can be tricky. You will not go and ask outside. Whom should I say? Thank you. Next, Monica.
A 30-year-old primary Avida at 38 weeks, 4 days of gestation, presents with vaginal bleeding for 2 hours. She is pale, pulse rate is 100 beats per minute, BP 140 per 90 mm mercury, fetal heart sound 140, USG reveals the placenta covering the arse. She was immediately taken up for LSCS. During LSCS, there was a retroplacental clot of 200 mm. What is her final diagnosis? Placenta A, placenta previa, B, abruptio placenta, C, A plus B, D, I don't
We
know.
have already given the answer. Just sit down. Pradeep has shown me watch. I think this is the last slide. Next is thank you. So I just take 1 minute, which many people, even PGs, don't understand this concept. I want to tell you this. A is the wrong answer. Okay? I did not teach you everything here, but if you go to the diagnosis definition